Everyone, thanks for tuning in. Today we're diving deep into a topic that is absolutely fundamental for every physical therapist out there, the hip and knee. These joints are the powerhouses of human movement. They carry us through life, taking our first steps, running a marathon, getting up from a chair. When they function well, life is good. But when something goes wrong in the hip or knee, it can drastically impact a person's quality of life. As therapists, you are on the front lines, helping people regain their mobility and live without pain. That's a huge responsibility, and it's why a solid understanding of these joints is non-negotiable for your practice. Think about the kinetic chain for a moment. The hip and knee do not work in isolation. A problem in the hip can manifest as knee pain. An issue with foot mechanics can travel up and stress the knee. Everything is connected. This is why a comprehensive assessment is so important. You're not just treating a sore knee, you are treating a whole person with a complex, interconnected system. Here's the hip anatomy: femur, acetabulum, labrum, and cartilage. One of the most common conditions you'll encounter is hip osteoarthritis. Think of osteoarthritis as wear and tear. The smooth cartilage that cushions the bones gradually wears down, leading to pain, stiffness, and decreased range of motion. Patients often report a deep, aching pain in the groin or the front of the thigh, worse in the morning or after inactivity, sometimes with grinding or clicking. Another frequent visitor is greater trochanteric pain syndrome, previously called bursitis. Often the pain originates from gluteus medius and minimus tendinopathy. These muscles stabilize the pelvis. Patients report sharp, localized pain, worse when lying on that side, walking or climbing stairs. Femoroacetabular impingement is extra bone growth that causes the bones to rub, which can damage the labrum, a gasket-like ring of cartilage lining the socket. Patients describe a C sign with catching or clicking, often provoked by deep hip flexion or long sitting. Hip flexor strains are common in sprinting and kicking. The iliopsoas runs along the front of the hip. Strain occurs when fibers are overstretched or torn, with sudden anterior hip or groin pain reproduced by lifting the knee or stretching the muscle. For hip osteoarthritis, our primary goals are to manage pain, improve mobility, and strengthen to offload the joint. Start with symptom relief and gentle range of motion. Exercises like pendulum swings and supine hip rotations help restore motion. Education is key. Modify activities that aggravate symptoms. Then strengthen glute bridges, clamshells, and sit-to-stands. Strong glutes and quads reduce joint load. For GTPS, manage tendon load on gluteus medius and minimus. Advise avoiding sleeping on the affected side and hip-hanging postures. Begin with isometrics to modulate pain. Progress to isotonic work and balance to build capacity and reduce irritation. For FAI and labral tears, manage symptoms and mechanics. Modify deep flexion, strengthen glutes and deep core without provoking pain. Let's pivot to the knee. This hinge joint takes a beating and is a common source of complaints. The ACL prevents anterior tibial translation. Tears often occur with sudden stops, pivots, or landings, often with a pop, rapid swelling, and instability. Menisci are C-shaped shock absorbers. Tears can be traumatic from twisting or degenerative over time. Expect joint line pain, clicking, catching, sometimes locking, and swelling that comes and goes. Patellofemoral pain syndrome is prevalent in athletes and sedentary folks, with diffuse aching around or behind the patella. Pain worsens with squatting, running, climbing stairs, and prolonged sitting, the moviegoer's sign. Multifactorial causes: muscle imbalances, poor biomechanics, overuse, leading to abnormal patellar tracking. Knee osteoarthritis involves progressive cartilage breakdown and bone-on-bone friction, with deep aching pain on weight-bearing, morning stiffness improving with gentle movement, swelling after prolonged standing, and crepitus. Post-operative ACL, manage swelling and pain and restore full knee extension. Getting the knee straight prevents long-term gait problems. Begin with quad sets and gentle heel slides. Progressively load quadriceps and hamstrings with mini squats, leg presses, and hamstring curls. Later, emphasize neuromuscular control with plyometrics and sport-specific drills. For meniscus injuries, reduce swelling, restore range, and avoid deep squatting and twisting. Strengthen quads, hamstrings, and glutes with straight leg raises, short arc quads, bridges, and single leg balance. Patellofemoral pain is often a hip problem. Abductor and external rotator weakness increases patellar stress. Use clamshells, abduction, lateral band walks, and pain-free quad work, plus hamstring and IT band mobility to rebalance forces. Sarah, 45, a recreational runner, has 2 months of lateral right hip pain, worse with running and side sleeping. Exquisite tenderness over the greater trochanter and painful weak hip abduction suggests GTPS. Educate on sleep and load management. Pause running. Start isometrics. Progress to clamshells, band abduction, balance, and glute bridges. At 6 weeks, pain-free and back to running with restored strength. David, 22, has anterior left knee pain, worse after practice and with prolonged sitting. No swelling or laxity, but lateral patellar tracking and weak left hip abductors and extensors point to PFPS. Focus on hip strength with monster walks, single leg RDLs, and core. Add pain-free quads and patellar taping. Addressing hip weakness corrects the root cause. These cases highlight the principle: diagnosis guides treatment. Test, intervene, and retest. Stay evidence-based, keep learning, collaborate with patients, and keep making a difference. One patient at a time.